Hey everyone, I'm going to do a quick review of Unit 2. This will not cover medications. I'm going to do psychobiology and psychopharmacology in a separate video just to kind of break up the content. This will include everything up until we get to the medications. We do have a lot of topics that we discussed in Unit 2. It is a very long unit. We talked about the stigma, shame, being flawed, the asylums that we had. That 1999 Olmsted decision basically says that, hey, keeping people in psychiatric hospitals isn't justified, and that individuals have a right to live within the community. We talked about psychiatric beds, but the number of state psychiatric hospitals, there were 322 state psychiatric hospitals in America in the 1950s, and we're down to 195 in 2019. So that was a huge loss of beds. We have a few different types of providers where we can get mental health care. Primary care providers are usually our first stop. We see our pediatrician, our primary care provider, and they are able to train them. We usually know this individual, and there's less stigma than having to go to a psych facility. However, it still can be hard to get these providers. There is no therapy, oftentimes it's medication management, and they don't have all of the training that our specialty care providers do. Specialty care providers can be psychiatrists, psychologists, advanced practice nurses, PAs, and therapists. So they have that educational background in psychiatry. So they are often better able to treat some of the more complicated cases. A patient-centered medical home is kind of that one-stop shop. Usually, we're embedding behavioral health professionals, care coordinators within another facility so that you can go see your primary care provider and psych provider in one building. Community mental health centers in this area is Integral Care and Blue Bonnet Trails. They have emergency services, home-based services, outpatient services, training courses, diversion programs, all sorts of resources for our patient populations. Psychiatric home care are usually for our homebound patients, and we go in the house, we're going to evaluate, we're going to teach, we're going to assess, are they taking their meds, how are they doing? Assertive community treatment is an intensive type for patients who can't always participate in traditional forms of treatment, and it does provide 24-hour support. Intensive outpatient and partial hospitalization are for patients who are stable enough to be home at night. However, they need more structure during the day. So in PHP or IOP, you basically wake up, you go to therapy throughout the day, you go home in the evening. Emergency care could be maybe a mobile crisis team, or we bring someone out into a situation. It could be going to an emergency department, calling 911, or ever we're kind of doing that triage and stabilization. So we talked about prevention and outpatient care. Primary prevention is everything we're going to do to kind of mitigate the risk factors. So what can we do to prevent the problem from occurring? So the example we talked about in class was substance abuse. I am going to teach kids not to use drugs, right? We're going to have that red ribbon program. We're going to talk about coping skills. We're going to talk about resilience in these communities and all of the different things that we can do to build up kids. Secondary, we want to identify early. Secondary prevention are our screenings. So when I go to the doctor does the audit. The doctor does the PHQ-9. Even though I'm not there for alcohol, depression, anxiety, we're still going to ask those questions to try to identify early and get that patient into treatment sooner. Tertiary, I already have a diagnosis of alcohol use disorder, and my goal is to get our patients into some type of treatment program. I want you to go to AA meetings every day to keep that disease from being as bad as it could be. Now, if nothing works and we have to go inpatient, we have crisis stabilization or observation units. Often these are like 24 hours, very short stay. We're going to get eyes on our patients, observe, treat, and then kind of figure out where we go from here. Usually what you see is a general hospital or private hospital. So Metroplex, I think there's a new name for it, but the hospitals in Killeen, Fort Cavazos, Cardansy, and what is or used to be Metroplex. We have a hospital, and in the hospital there is a floor where they take psychiatric patients. Usually more so in this Austin area, what we're going to see is we have a private hospital, Cross Creek, GBHI, the facilities that we are going to, It's a freestanding hospital, and all they take are psychiatric patients. We do have state hospitals. They are usually forensic, though. Court-ordered observation, long-term care. An example, if y'all remember her, Andrea Yates, she was found not guilty by reason of insanity. It is a postpartum psychosis case. She killed her children. She was committed to a Texas state facility for treatment because of her trial. Some things to consider when we're talking about inpatient care: 24-hour supervision. We should have locked, most of our places, at least where we're going, are locked units. The patients cannot leave. They cannot open the doors on their own. The doors are locked. There are some unlocked facilities. When I worked in addiction, because there wasn't the risk of suicide, it was unlocked. We do have to be mindful of patient leaving when they're not supposed to, kicking down doors, stealing badges. Just because we're in a psych facility does not mean we don't have rights. Our patients honestly maintain almost all of their rights unless there is something going on. Our patients have a right to receive mail, to make phone calls, to see their priest, their rabbi, whoever. They have a right to privacy unless they're suicidal. Treatment team are who works in these facilities: psychiatrists, advanced practice nurses, therapists, counselors, occupational therapy, rec therapy. You'll often see psychologists. Our psychiatric techs are a big one. The therapeutic milieu is the environment, and kind of goes along with that unit design. We looked at some of the pictures. We want it to be calm. We want everyone to kind of be stable and doing okay. If we have one patient who gets a little bit more acting up, it's going to affect everyone else. We do have this sample floor plan. We got the nurses station in the middle with the patient rooms around. I honestly have never seen a layout like this in this area. I guess it's one that could be used. Our facilities are a little bit different. National patient safety goals. There are some that are specific to mental health. Identify patients correctly, so name, date of birth. Sometimes in psych, if we have a patient who cannot communicate all that information, we're going to use name, date of birth, or picture. We want to use medications appropriately. We're going to record them. We're going to make sure they're okay. We're going to make sure that we're providing education about the medications before we give them. Make sure the patient has an up-to-date list. Prevent infection, hand hygiene. A lot of that infection control, gloving, making sure we're doing what we can to keep our patients from getting sick. Assess the risk for suicide is a huge one that goes along with mental health. Our doorknobs are going to be different. Our toilets are going to be different. The shower curtains in our patient rooms are going to be Velcro. There's not going to be the hinges on the top of doors. A lot of that strangulation, especially the sharp object risk, is going to be taking into consideration. We can talk forever about different things we need to do, and we'll talk about suicide throughout the course, so we'll touch on that again. And then healthcare equity. We want everyone to be able to have access to healthcare, regardless of who they are. And it's hard in America. Healthcare is expensive. We do have some specialty treatment settings. There are some specific pediatric facilities. There are some specific geriatric facilities where that's all they're going to take. We do have some pediatric and geriatric units within our facilities. And then the VA has a whole bunch, so many resources for veterans. Addiction treatment, women's treatment, vet centers, all sorts of different access for veterans. Theories and therapies. We talked about just a brief few, and we're going to remember that we are in a psych nursing class, not a psychology class. So more so, how are we going to think about this as nurses? If a patient asks a question, what is psychoanalytical therapy? What is behavioral therapy? What are we going to tell them? So when we think about Freud, he's very much that unconscious. The majority of our mental illness comes from unresolved situations from childhood. He did have his different conscious, preconscious, unconscious, id, ego, superego. We're not going to go too much into that today. Defense mechanisms we will talk about a lot when we get to our anxiety section in chapter 15. Please do not go memorizing defense mechanisms now. However, it's that unconscious, these distortion of reality are coming, and we're not choosing to use it. It is just happening. Psychoanalytical therapy is kind of that old school. We have someone sitting reclining on a couch, and the therapist is sitting there, taking those notes. We're going to listen, get the person to talk, try to make those connections, and get them to dive into that unconscious. I'm going to skip through some of these videos that we watched in class. Interpersonal theory. Psychiatric problems are focused on interpersonal problems. Humans are driven by this need for interaction. Loneliness is a painful human condition. Having those relationships, learning how to form those relationships with our patients, with our family, with our loved ones is extremely important. And it helps develop our personality. Interpersonal therapy is great for short-term use. We want to eliminate psychiatric symptoms by improving how we're interacting with others and having satisfaction in those social relationships. Oh, this is why I can't use buttons, y'all. Okay, Hildegard Peplau came from interpersonal theory, and she is the first psychiatric nurse. So she has her whole theory of interpersonal relationships in nursing. She founded psychiatric nursing practice. She really did look at the fact that nurses, it's not what are we doing to our patients, and what are we doing with our patients. We can provide care, compassion, advocacy. We can enhance comfort and well-being. She really took this application of knowledge, the broad range of human problems, and applied it to our patients. How can we decrease their suffering and promote growth? We talked quite a bit about behavioral therapies, just because there's a bunch of them. Behavioral therapy, we want to work at changing a maladaptive behavior by controlling the environment. We are either doing something that we want to stop or not doing something that we need to start. So classical conditioning is that dog. I'm going to ring the bell and give the dog food. I'm going to ring the bell and give the dog food. I'm going to ring the bell and give the dog food. And all of a sudden, every time I ring the bell, the dog has learned I get food. And it very much becomes an involuntary response. Behaviorism in Watson, it looks at kind of the behavior. How we are learning through social environments. Operant conditioning is rewards and punishments. My kid cries at the store, dad buys him a gift, a toy. My kid learns, hey, look, if I yell and scream and cry, dad's going to buy me a toy that I want, right? Every time dad buys that toy, he's reinforcing that negative behavior. So me, on the other hand, I'm going to go and I'm not going to buy you the toy, and I'm going to let you have this, and eventually you don't yell or scream anymore because you learn, well, mom's not going to buy me the toy. It doesn't matter if I yell or scream. If we're trying to potty train someone and we're using a sticker chart, that is positive reinforcement. Every time you go potty, right, you get a sticker. So behavioral therapy, again, the assumption that changing the behavior can occur without understanding the underlying cause. So modeling, right, role playing, how we're acting around our patients. The patients pick up and they learn through that imitation. Operant conditioning, again, is a behavioral modification. Hey, look, if you get all A's, I'm giving you $100. If you pick up your toys, I'm going to give you XYZ. Systemic desensitization, it has to do with fear. You're afraid of something, and little by little, we're going to expose you to what you're afraid of. So if you're afraid of a spider, I'm going to start with like a picture of a cute cuddly, a picture of a real one, a plastic spider, a cute stuffed spider. We're going to watch Charlotte's Web. I'm going to then show you a daddy's long legs, and we're eventually going to show you what you're afraid of. Again, this is done in a nice, safe, controlled environment with the therapist. We also talked about flooding. Again, nice, safe, controlled environment with the therapist. But if you're afraid of spiders, I lock you in a room full of spiders. And I put you in that room of spiders, and you have to very quickly learn, hey, look, these spiders aren't going to hurt me. Aversion therapy, biting your nails. If we put the stuff on that make it taste bad when you try to bite your nails, you're going to stop biting your nails because you're like, negative stimuli, this tastes bad every time I do it. Antabuse is a medication for alcohol use disorder. If you take Antabuse and then you drink alcohol, you get very sick. So eventually we learn, hey, look, if I drink alcohol, I get sick. So our body stops craving the alcohol. So not talked about in this PowerPoint is cognitive therapy. And cognitive therapy has to do with changing our thoughts. So in behavioral therapy, I didn't care about your thoughts. I wanted the maladaptive behavior to become a positive behavior. And in cognitive therapy, there's no look at behavior. In true cognitive therapy, I want to take a negative thought and turn it into a positive thought, that cognitive restructuring. Aaron Beck tied the two of them together. Hey, it really does look My irrational belief is not accurate, sensible, or useful. My thoughts are not taking the form that they should, right? There's this activating event. I have this belief about the event. I have my emotions as a result of the event, and then I have my actions as a result of the event. So I try to tie it all together, and that connection between thoughts, emotions, feelings, and actions is the big component of CBT. It is widely used today. Depression, anxiety, phobias, pain, very much one of kind of like our gold standards. Maslow's we did not talk too much about because this is one y'all should already know. Humans are motivated by unmet needs. We have to start at the bottom. If we have no airway, breathing, circulation, right, vital signs, no place to live, suicide, right? Maslow's suicide, self-harm, right, death is in this bottom one. Those are going to be our priorities. After that, then we tend to go up, can I keep a job? Do I have health insurance? Love and belonging, my relationships with other people, my family, my loved ones, my friends. Respect for myself, self-esteem comes next, and then that self-actualization. Can I be everything that I can? If our lower needs are not met, we will not be able to meet our higher needs. We did talk some that we have these developmental theorists, Piaget, Erikson, and Kohlberg. In this class, we're really just focusing on Erikson. And Erikson was kind of the opposite of Freud. He thought Freud was too restrictive and too negative. And Erikson, has 8 stages, which results in a positive or negative outcome. I would be very familiar, especially, right, because in that opposition to Freud, Erikson really says that independence and self-control happens through those early years. That trust versus mistrust, that I can do things on my own. Am I good enough? That competence development is really happening from infancy through that school-age child. Identity versus role confusion. What am I going to be when I get up? Intimacy versus isolation. My friendships, my relationships, right? My partners. Generativity versus stagnation. Am I just going to stay in the same job? Or am I going to do things to better myself? When I have free time, am I just going to like scroll TikTok mindlessly, or am I going to come up with a hobby? Ego, identity versus despair, that maturity 65 to death, that reflection. If I'm sitting there in that rocking chair at the end of my life and I look back on everything that happens, am I going to look back with fulfillment, or am I going to look back with like regret? Skip the little Erikson video. Culture. We did go very fast through culture because culture is generally something that you have talked about before. We do just have a lot of material in this unit. So beliefs, values, religion, geographic, communication, all of this plays a role in the intersection of culture. We do have a few different types of culture. Eastern culture, family is a starting point. It tends to be more conservative. Disease is caused by that lack of balance. In Western culture, we tend to have self as a starting point. There's less emphasis on the family, and we're very much more individuals. There is a pathogen, and that is what causes diseases. Western culture tends to express emotions more openly, while Eastern culture may be more subtly. We'll talk about that misdiagnosis, that stigma, the somatization. We are more likely to see somatization in an Eastern culture. It's just that expression of pain, that headache, that nausea, when really what is going on is anxiety. So indigenous culture, we tend to look at the community as the starting point, and there's more of a respect for nature, mind, body, spirit united. Again, that is a very broad, a very, very quick overview. We could go through these in so much more detail because, again, even within Western culture, right? If we just look at America, depending on where you live in America, it's going to be different. We have different words and different dialects depending on which part of the country. We can have a few people in America who have the same religion, but how they practice that religion is different. All of it is just, it's going to be very much dependent upon our patient. Communication, verbal communication, again, different languages. We have to make sure we have an interpreter. We have to make sure we have documents that are translated for our patients. Nonverbal communication, personal space, touch are going to be varied depending on the person. Some cultures, some individuals may believe touch is more of an invasion of privacy. They may want kind of that distance in between. Some cultures, some individuals are more okay with touch. Stigma is going to exist across all sectors. However, we do have some cultures that does see mental health as more of a failure. It does see it more as of a weakness, and those especially are those patients where we're going to see that misdiagnosis, that somatization, that internalization of these feelings. It is easier to talk about a headache than it is to talk about anxiety. We do have a few populations at risk for mental illness. Immigrants, there's a language barrier. They're coming into a new change. They're picking up things that acculturation. They're assimilating. They're kind of getting used to the culture that they're in, but then also trying to bring in some of their culture from wherever it is they're coming from. Immigrants, when we look at refugees, immigrants who have to flee, it is not voluntarily entry against their will. It's a little bit harder because we have that additional stress, that a trauma from whatever it was that is happening. If we talk about like a war zone and we have people who are fleeing and having to seek refuge elsewhere, you have the trauma from that crisis, the stress of adjusting to the new environment, the language changes, especially when you might not have ever wanted this. Cultural minorities are frequently the victim of bias, discrimination, and racism. And we have to think there's so many different types of cultural minorities that are out there. When we look at race, sexual and gender minorities, the list can go on and on and on. And we very much have to consider each and every one of those as we look at that cultural competence. That cultural awareness as a nurse, we have to consciously be assessing ourselves, our own biases, how we're interacting with patients. In every relationship, there's 3 different cultures, the patient, the nurse, and then the setting that you're in. It is going to be different. If we are not sure about what is going on with our patient, we have to learn. It very much sounds silly, but if I have a patient and they're like on the phone with their root healer, and the root healer is making recommendations, I'm going to talk to this root healer. Because if I just disregard the root healer, the patient's not going to always give buy-in. And I need the patient to give buy-in too. Attain different events to gain that knowledge, continue to educate ourselves. As we are approaching learning about different cultures, 1, we build confidence the more that we do this, but 2, we also have to be mindful of stereotyping. We can't just look at that patient, those internal biases, and be like, hey, no, this is what is going on. Every individual is going to be different, so we do have to have that open look and not just resort just to culture. Cultural skill is doing that assessment in a sensitive way. Do we have someone who covers their hair, right? Especially if they're covering their hair and they don't want to take it off in front of males, right? We have a male nurse and you're like, but I need to look at your head, right? Get a female nurse, right? Close the environment, make the adjustments to make that patient feel more comfortable. And again, we talked about it in general when we're taking care of patients. It's not just out of duty. We have to have a sincere concern for our patients and a sincere concern to want to learn and grow and learn about our patients. Legal and ethical decisions. This is a lot of gray area. In class, we will have gone over a bunch of the specifics. So just kind of be mindful, reach out with any questions. So ethics, what is right and wrong in society? Bioethics, specific issues related to healthcare. So we saw this a lot over COVID. We had 1 ventilator and 2 patients who need the ventilator. Who gets it? How do we make that decision? Beneficence, do good. Autonomy, we have a right to make our own decisions. Justice, the example I always give is my 80-year-old patient with heart failure and my 20-year-old IV drug user with endocarditis. We should be treating them the same. They should have the same access to resources. However, oftentimes we're like sweet old lady, heart disease over drug addict with endocarditis. It should be fair regardless. Fidelity, maintaining loyalty, keeping up our nursing skills. If we tell a patient, hey, I'm going to come back in an hour, coming back in an hour. And then veracity, being truthful. I think the big one in mental health, it's like, hey, does my medication have side effects? Nope, no side effects whatsoever. But we have to tell our patients the truth. So there is a code of ethics for nurses. If you have never read this, I highly recommend it. It is very interesting. We need to practice with compassion. We need to respect our patient's uniqueness, our commitments to the client. And everything we should do should be to protect the client's rights, health, and safety. However, we also owe the same duty to ourselves, a right to competent help, right, in our techs and our coworkers. If you've never read the Code of Ethics for Nurses, like I said, you should. There's a section that actually says, like, hey, if your facility isn't doing what it's supposed to do, you have the right, like you have the duty as a nurse to quit and report that facility. So we just have to be mindful of everything when we're going through it. In mental health, this is where it gets different than anywhere else, our medical side. We have a few different types of admission. A voluntary admission is I understand that I need treatment. And I drive myself to the psych facility and I'm like, look, I'm struggling. I have this stuff going on. I don't think I can be safe, right? I'm having these thoughts of suicide. I need help. And I'm voluntarily seeking out care and I'm signing myself in. A voluntary patient I've signed myself in, but I still have the right to refuse medications. And I still have the right to request to leave AMA when I'm voluntary. An involuntary admission is court ordered. It could be an emergency kind of commitment too. They go the same. So in Texas, we have what's called a notification of emergency detainment. You have a patient who's threatening to jump off a bridge and the police get called. The police come, they take the patient, they take him to the ER psych facility, and it is actually a one-page piece of paper that the police fill out, and the patient now has a 72-hour hold. That is that emergency commitment. So the patient is doing something dangerous, we hold them for 72 hours. While the patient is there in that 72 hours, they still have a right to autonomy. So, in an emergency commitment, the patient can still refuse medications. They cannot leave AMA. My voluntary admission could leave AMA. My emergency commitment cannot leave AMA. They are here for 72 hours. I don't care if their family is going to pick them up. They are here for 72 hours. In that emergency commitment. Now, my emergency commitment can still refuse medications. Just because you have to be at the psych facility does not mean I'm going to force medications on you. Now, if my emergency commitment patient, right, was jumping off the bridge, psychosis, they're refusing medications, they are not getting any better. We then can take the patient to court in this area. It's called an order of protective custody. And that is that involuntary admission here in the middle. And in that involuntary admission, a judge is saying the patient needs to be in the facility. And that could be 30, 45 days. Like usually the patient will be admitted up to 45 days. Now, just because someone has an involuntary admission does not mean we are going to force medications. There has to be a specific court order in that involuntary admission to force medications. So 90% of the time, we are not forcing medications on our patient. So voluntary admission, I sign myself in. I can still refuse medications. I can request to leave AMA. An involuntary admission, a judge has ordered that I am at the facility because any one of these reasons, stage yourself, others can't, I'm getting worse, I'm decompensating, psychosis. And in that involuntary admission, I'm at the facility at whatever it was determined by the judge. I can still refuse medications. I cannot leave AMA. My emergency commitment is done by police. It is a 72-hour hold. The patient gets taken to the facility. They can still refuse medications, but they cannot leave AMA. They are there for 72 hours. Assisted outpatient treatments, that's that like IOP and PHP. That basically is you will go to outpatient treatment. And the patient doesn't have a choice. So in our discharge procedures, I honestly would not worry about conditional or unconditional. Most of what we see is an unconditional release. The patient is discharged, they leave, and we don't see them again. And that is the end of it. Conditional release is basically like, hey, you're discharging from inpatient, but you have to be outpatient for so long. So release against medical advice. We know for the most part what that is. I'm like, look, I don't want to be in the hospital. I don't care what the doctor says. I am leaving. And for the most part, and I'm going back to the slide for a reason, for the most part in medical, if my patient says they're leaving and they're competent adults, I'm just like, okay, bye. And we sign the paperwork and we let them leave. When I worked in addiction, if you want to leave MA, I'm like, great, here's the paper, sign, you left. However, when it comes to talking about acute inpatient psychiatry, we have to take into consideration danger to self or others. So my patient voluntarily was admitted, they have signed themselves in for being suicidal, and now they want to leave AMA. But we believe they're going to leave and they're going to kill themselves. So even though they were voluntary, I can keep them from getting discharged because there is a risk of danger to self or others. And same thing, involuntary admission, because it's court ordered, they cannot leave AMA. And emergency commitment, because that is that 72-hour hold, they cannot leave AMA. Now, client rights, right to treatment. So they have a right to receive treatment, quality treatment, and they have a right to refuse treatment. So if my patient is admitted voluntary or even involuntary, and they don't want to take their medications, they don't take their medications. However, there is an exception. If we have someone who is violent, a danger to self or others, then we may medicate against the patient's will. I always kind of compare these violent clients to your code blue. So if we have a violent, aggressive client in psych, that is usually code green, code yellow, depending on your facility, right? It's our psych emergency code. So if I have to call an emergency code on a patient, it's very much the same as having a code blue called. So if you're working in a hospital and a code blue is called, right, medical, you're going to go and you're going to start CPR. You're going to go through, right, bag your patient, whatever the steps are in your facility for code blue. You're not necessarily asking the patient like, hey, are you okay with this? Unless maybe there was some predetermined, right, and that gets into advanced directives. But if there's a code blue, we just pretty much go ahead and go through our code blue protocols. If I have a violent client, they're aggressive, they're hurting themselves, they're hurting others, in that code, that is when we can give enforced medications against their will. Now, if I have a psychotic client and they're there in that order of protective custody, I can also have a judge order medications. So I may have court-ordered medications. And that is a time where the patient pretty much gets told, per the judge, you take this Haldol orally or you take this Haldol in a shot. And the patient has to take it. It is court-ordered. The judge has told us they have to do it, and we have to follow that court order. All of our patients have a right to informed consent. So we do have to talk to them about their options, benefits, treatment risks, and history. Right? And it's hard sometimes because they're not always in the right state to do it. So we have something called an advance directive, and we have those medically, but we also have what's called a psychiatric advance directive. In 15 years, I've only met one patient with a psychiatric advance directive. It basically says if something happens, this is what I want to happen to me. Very much similar to our regular ones. If I have a patient in psychosis and they have an advance directive and it is not signed, I can't get them to sign it. If I have a patient who is unconscious and there's an advance directive and it's not signed, I cannot follow it. We then have to reach out to that next of kin. So restraints and seclusions are only for a medical emergency, psychiatric emergency. We have to try something else first. It is not for convenience. It's when we have tried everything else. We have a few different types of restraint seclusion. We can manually hold someone. Let's skip a slide forward so y'all can see. So this bottom corner over here where there's the two people holding the person in the middle, that would be a manual hold. We have a physical restraint where we're doing the old school tie downs. We have actually restraint chairs nowadays, all sorts of different categories. We have seclusion where I'm just going to lock you in a room by yourself. That actually sometimes is the most humane and okay to do. And then we have chemical restraints. I'm going to give you a whole bunch of medications, so I basically sedate you. Confidentiality, HIPAA, clients must give consent to release information, especially with mental health care, right? Clients have a right to privacy. All of that, they have a right, and honestly, when we talk about that right to privacy, they do have a right to privacy. However, like we said in class, if you're a danger to yourself or others, if I have you on a one-to-one for suicide, I'm not taking my eyes off of you. I'm going to watch you continuously because of that risk. So we do have some specific laws for mental health care. Intentional tort is willfully violating another person's rights or properties. And some different types of intentional torts are assault. You make a threat to someone else. Battery is actually putting your hands on and harming someone. So the way, actually, I had a student one quarter teach it to me. With assault, you make an ass out of yourself, and with battery, you're hitting someone with a bat. So if I tell a patient, hey, listen, if you don't stop running up and down the hallway, I'm going to put you in restraints. That is assault. I have threatened the patient. Now, if the patient continues just kind of running up into the hallway and they're not a danger to themselves or anyone else, and I put my hands on the patient, that is now battery, that touching of the patient. Now, if I take the patient and I put them in restraint or seclusion and it was not warranted, that is false imprisonment. So if I place a patient in seclusion and they should not have gone in seclusion, that is false imprisonment. So with some of those unintentional torts, we have negligence and malpractice. Negligence, we're not going to do the normal care when we have a duty to do so. Negligence is one of those most common, and that's very much orderly care. So maybe if you get a physician's order and you're like, this is a really weird order, why would the doctor order it this way? And you just kind of like shrug your shoulders. And you're like, well, this is what the doctor ordered. So we didn't question the order. That would be negligence. Malpractice is a special type of professional negligence. There are 5 elements required to prove it: duty, breach of duty, cause and fact, proximate cause, and damages. So we're going to give an example. We have a patient who is suicidal and they're supposed to be like on cue 5-minute checks, but I'm really busy and I'm supposed to be the one checking on this patient, right? So I owe a duty to the patient to check on them every 5 minutes, but I'm really busy and I'm like, they'll be fine. And I don't round on them every 5 minutes. That is a breach of duty. Now, when we go and eventually check on the patient, we find them dead, right? They choked themselves with toilet paper. I did not round on that patient. It caused the patient harm. Cause and fact and proximate cause. Damages to the client is now dead, right? If we're giving an IV medication, it's a vesicant, and we are not checking it like we're supposed to, and there is damage to the patient's arm, that would be malpractice, that professional negligence. We had a duty to check the medication. We let it run. We did not do it. We breached our duty and it hurt the client. We've talked about documentation before. Again, accurate and complete information. The purposes of the medical record are to provide that accurate and complete information about the care and treatment of patients, to give healthcare personnel means of communicating with another, right? That continuity of care. It's useful, right? How useful it is determined by how accurate and complete it is. So if we're actually talking about our patients' behaviors, right, their mental status, what is going on, that is very helpful. Most of the time, and I don't know, for some of y'all who have not worked, it's a little bit different. In mental health, our patients' length of stay is honestly always determined by the insurance company. And we have patients who need to stay longer, but the insurance company just says, nah, they're good. And we don't have the documentation to back up why they need to stay. The patient does have a right to see the medical record, but it does belong to the institution. They have to follow the protocol to view the record, and then we can't just release the record. I can't just go and get my husband's medical record. He has to okay it being released to me. We have to document timely. We can't back chart, right? We shouldn't be crossing things out. We shouldn't document ahead of time. I gave these medications at 10 o'clock and it's only 9:30, but I'm going to give them at 10 o'clock. Well, we don't know what's going to happen. And that is actually the end. I'm going to do biology and psychopharmacology separate, so this is not too long. If y'all have any questions, let me know.